I just did this endocrinology quiz. I was doing great initially, but towards the end got several questions wrong, as you can see here. Several questions wrong at the end. Not sure if I was paying enough attention or not, because I was in clinic seeing patients and trying to do questions in the middle. All these questions, the initial questions, I was giving complete attention to the quiz, but nonetheless, I want to go through whatever pearl I learned. So let's see if there's anything special I learned from these. So question one, you can see here, basal and prandial insulin. So what's this one? Let's see. Women with gestational diabetes who are unable to meet glycemic targets with therapeutic lifestyle intervention should be started on insulin therapy. Insulin is preferred because it doesn't cross the placenta to the same degree as other medications. Okay, so remember, you have to have very strict insulin control or glucose control of the pregnant mother, right? Because if not, you are just risking complications for the fetus mainly, and I guess increasing risk for diabetes later in life for the mother. But the major risk will be for the fetus, because they're gonna generate the macrosomia, labor and delivery complications, preeclampsia, neonatal hypoglycemia, abortion, intrauterine fetal demise, etc. So, what are the targets? Less than 95 milligrams per deciliter fasting, and less than 120 2 hours after a meal. That's, yeah. Okay, in this case it says a meal, but I'm used to the glucose tolerance test, which for a pregnant woman is different than a non pregnant. I think a non-pregnant person, that is usually not done that much anymore, that not that frequent, although it can be useful. I think pregnant a female was 100 grams of the sugar or glucose carbs, and a non-pregnant was 75 grams. But correct me if I'm wrong. Okay, let's go on to the next one. So let's go on to question two. This thing right here, yeah, it looks, this is like the buttocks area. It looks like dermatitis herpetiformis, I believe, associated to celiac disease. So what are you gonna test? You're gonna test the transglutaminase antibody, because it's highly sensitive, and that's the first step to do the lab before you do all these other things. If it's negative, I think it has a rather high negative predictive value. And this patient, what was interesting that was that the patient had type 1 diabetes. So yeah, type 1 diabetes is autoimmune. It can be associated as well with other autoimmune things, such as, here you have it, celiac disease, autoimmune disorders, thyroid disorders, vitiligo, pernicious anemia, autoimmune hepatitis, and autoimmune primary adrenal gland failure. Let's go on to the next one, okay? That's not what I want to do. Let's go to 3. Stop biotin. Okay, what's this telling us? Okay, in this case, it's just letting us know that if a patient is taking 10 milligrams per day or more of biotin, they should discontinue the ingestion in case they have abnormal TSH in a lab. So in this case, the TSH was suppressed, and that's because biotin interferes with TSH level. So high biotin may interfere with the assay that use streptavidin biotin as an immobilizing system. So yeah, it can interfere with that. Although biotin is also found in plants, the richest source is liver, egg yolk, soybeans, and yeast. And adequate intake is estimated to be 30 micrograms per day, and larger doses okay, are common, taken as adjunctive medical treatment or for perceived health benefits. Okay, so let's go on to the next one. In this next one, chest radiography. Okay, in this next one, what was going on is that the patient has hypercalcemia and an increased 125 vitamin D level, as you can see here. It's 97 and the cutoff is 65. So what the question is asking you is like, how can you search for the cause? And when you have this increased vitamin D level, yeah, chest radiography is a good idea because you can have, I'm thinking of sarcoidosis here, but what else can it have? Can also occur in granulomatous tissue, disease tissue associated with fungal infection, tuberculosis, sarcoidosis, and lymphoma. So a chest x-ray is probably a good idea for you to scan. Okay, so let's go on to the next one. And we already got that one, gynecomastia. So Pearl here is, when you read of gynecomastia, you're like, oh yeah, there's increased glandular tissue, but what's the cutoff? So the definition, technical definition, is glandular tissue more than 0.5 centimeter in diameter, right? For a male is going to be gynecomastia. So that's a nice pearl. And when the etiology of gynecomastia is not clinically apparent, initial laboratory evaluation includes serum or measurement of human HCG or chorionic gonadotropin LH, which is luteinizing hormone, estradiol, and 8 a.m. fasting testosterone. Okay, so that's about it for this. Let's go on to the next one. This one, okay, this is a nice question because it basically gives you a case where you have all the findings concerning for diabetic ketoacidosis, but the glucose is not normal, but it's a little bit elevated, but it's nothing like crazy elevated as you usually see these patients in DKA that they have a glucose into the hundreds, right? You know that hyperosmolar state, sometimes the glucose is usually even higher than DKA, but we're talking about hundreds, right? To even thousands, that can even happen. So, what's the thing here? The learning point here is that this patient has all the findings suggested for DKA, including the beta hydroxybutyrate elevation, and it takes canagliflozin, which is an SGLT2 inhibitor, and these medications are associated with euglycemic DKA. So that's the main pearl from here. And presence of an ANA and GAP metabolic acidosis and elevated beta hydroxybutyrate suggests the diagnosis of diabetic ketoacidosis. So we already talked about that. Next question. Okay, now let's see what's the pearl here. Basically, in this question, they're asking you like, which is the best medication for you to start in a patient which is diabetic with an HbA1c of 8%. So first thing you have to decide is, yes, this patient needs medications, and yeah, you're not getting out of it because no option is like do nothing. So you need to give some medication. Usually on these tests, whenever you see the thiazolidinediones options, usually pioglitazone, rosiglitazone, I think it's rosiglitazone.
Here's what I found.
And those two usually are not good options. So you basically will never answer on a test thiazolidinediones because they're associated with usually heart failure, dilated cardiomyopathy, and they increase the insulin secretion, might be associated with hypoglycemia, etc., etc. So they're not also good idea in old patients, etc. So you have these other options, and of course another thing to take into account is you have to always see these patients as which patient has cardiovascular risk factors. If they do, you will probably lean towards SGLT2 inhibitor and or better said a GLP-1 agonist, right? So in this case, the closest thing is the dulaglutide, because glipizide is I believe it's a DPP4 inhibitor. So yeah, of course, this is a cappella. So if I make any say anything incorrectly, just call me out, and we're here learning. So, but I'm not gonna like stop this video just to look this up. Wouldn't make sense. Um, Insulin, I'll let you know whenever I'm not sure. For example, glipizide, I'm like, is this DPP4? Glipizide. I think so. It's not a GLP-1 for sure. Yeah. So, and it's not a thiazolidinedione. So since I just mentioned that, let's just look it up. So we confirm glipizide. Glipizide says, what is it? Sulfonylurea. Okay. So it's a sulfonylurea, so not a good idea. I think, don't remember regeneration, but okay. Whatever. That's not the answer. We have two. They won't make you choose between two thiazolidinediones, okay? And insulin, yeah, it's usually a great answer to lower glucose, but is it lowering cardiovascular risk? No. So, whenever you can get to goal without insulin, that's the first thing to do. And whenever you have uh, burnt all the bridges, you have to go to insulin. Okay, so now let's go on to the next question, and we're going to go here. This one I marked it incorrect, so let's see why it was. So in this case, which medication changes would most benefit this patient? Here you can see an example. This patient is on metformin, 850 milligrams twice a day. I thought, actually, I had a patient today on 1 gram twice a day, and I was like, can I go up on the metformin? And the answer was no, because up to date says that the maximum dose is 850 twice a day. So this patient is actually maxed out on metformin, so that would make this option incorrect. And why not the other options? Let's see, why not dapagliflozin, which is an SGLT2 inhibitor? Um, because the patient lifestyle including low carb, weight loss, exercise, see, recurrent urinary tract infection. So one thing that usually you'll see in the literature against SGLT2s is that since you're peeing out all that glucose, it might increase the risk for UTI, which clinically is sometimes has been demonstrated that significance isn't probably that much, but it's more of a theoretical thing. But for the test, if there's a better option, you'll mark the better option. It's liraglutide. So insulin secretagogues, including sulfonylureas, thiazolidinediones, and insulin often cause weight gain. So this patient was also trying to lose weight. So yeah, so medications associated with weight loss are GLP-1, SGLT2 inhibitor, alpha glucosidase inhibitors, and amylin mimetics. So if you're seeing this video, give me a couple or one example of an alpha glucosidase inhibitor and then amylin mimetic if you remember it. Okay, so that's about it for this question. Let's go on to the next one. Vaccine. Okay, so this one I recently saw a patient in clinic. Actually, our Epic gives us what care gaps we should fill out, and there's a special thing that you can click on that gives you even more recommendations. And there was the hepatitis B vaccine, so that's how I recall that it probably had to do something here as well. So in summary, I was between option A and D, but there are some of these pneumococcal vaccines that if you get one, you don't need another one. So if you got the 15, you need another one. If you got the 20, you do not need another one. The other one is usually the 23 valent, which is this option. So in this case, probably doesn't need the 23 and probably needs the hepatitis B because the patient has diabetes mellitus, I believe. So adults 19 through 59, as well as above 60 with certain diseases such as diabetes, should receive hepatitis B virus vaccination. So that's this answer for this one. And let's go on to this next one. Okay, this patient, what was interesting here is the patient had hypocalcemia. Patient had a hyper or increased alkaline phosphatase. So those two findings, and phosphorus was normal. So the caveat is that in patients with vitamin D deficiency in adulthood, also known as osteomalacia, initial findings will be first alkaline phosphatase goes up, and then you'll have low calcium and high phosphorus. Okay, so that was the main thing. Chronic deficiency, okay. And in patients with osteomalacia, progressive rise in total alk phos precedes overt hypocalcemia or hypophosphatemia. And let's go a little quicker. Okay, this question I got it incorrect because I saw this scintigraphy and I was like, this radioactive iodine uptake scan. And I was like, what's this going on right here? What should we do about this? I had no idea. This is basically the thyroid getting the radioactive uptake, and this is probably the bladder because, of course, you have to pee this out. So this patient, what they needed was atenolol for the symptoms. The patient did not require methimazole or propylthiouracil because the TSH was in the normal level. So they would need these other medications if it was in. Let's see what it says. Radioactive iodine uptake is high, more than 30% or inappropriately normal in hyperthyroidism due to Graves, and low, less than 10% in other causes of thyrotoxicosis such as destructive. So in this case it was high, so it was probably Graves, and yeah, that's what it's used to distinguish between Graves and other causes. One, defining the cause helps dictate the use of anti-thyroid medications, symptomatic treatments, or anti-inflammatory treatments. So why atenolol? Because the patient has symptoms. That's what you want to treat first. And since the, let's see, hormone TSH level is suppressed and elevated T4, laboratory study shows. Yeah, so I'm not sure why you wouldn't do the methimazole and the propylthiouracil. Let's see why right here. Because this patient does not demonstrate excessive thyroid hormone production, methimazole or propylthiouracil is not indicated. So the TSH is depressed, but T4, so it's subclinical. T4 is a little high, so it's clinical. It is clinical. Okay, so this might be problematic. This option might be problematic. I understand now why you could mark methimazole and propylthiouracil, because this is clinical hyperthyroidism. Not sure. Okay, that's about it. Yeah, that's it. The end. There's other questions, but that's enough.